start talking about the bony joint of the elbow, and it's composed by the distal humerus and the proximal forearm, and this is just a mechanical constraint for the stability of the elbow because of the shape of the joint. But the joint is still enforced in its stability by the ligaments and by the capsule that go all around the articulation. Now we show the static stabilizer of the elbow, and we divide it in the primary, in which we meet the ulnar-humeral articulation, in particular the olecranon and the coronoid process. And then we have the complex of the medial collateral ligaments and the complex of the lateral collateral ligaments. The same thing when we talk about the secondary stabilizer, we have the radiohumeral articulation, and we talk about the radial head and the common extensor tendon, common flexor pronator tendon, and last but not least, the capsule. Starting with the ulnar-humeral articulation that maybe represent the most important bony stabilizer with the coronoid process and with the olecranon. The olecranon is a bony stabilizer and is seated within the olecranon fossa in a distal humerus. So maybe the main contribution of the olecranon is when the elbow is in full extension, giving a constraint. Both in varus and in valgus and in rotation. There is a study in which is explained how the contribution of the olecranon to the elbow stability is not so important like maybe other structures. In effect, when we will have the resection of most of the 87% of the olecranon, we will have a severe instability of the elbow. This is not the same for the coronoid process that maybe is the most important bony stabilizer of the elbow, especially in flexion, in which the elbow is stabilized through an interlocking of the coronoid by the ulna with the coronoid fossa by the humerus. And this is explained by the anatomy of the coronoid process that I repeat is the most important bony stabilizer, because in the sagittal plane we have an osseous block that prevents posterior translation of the ulna, and in the frontal plane we have an anteromedial facet that limiting the varus valgus stress of the elbow. The articular surface of the coronoid process is complex, and maybe we have 4 key points. The first is the semilunar notch, in which we have the joint with the radial head, then we have the apex, then the anteromedial facet, and then the sublime tubercle in which the MSCL is inserted. We can have different shape, we can have different morphologies of the olecranus, so the most of them are not always the same. Many structures have their insertion in the coronoid process, like the articular capsule, the annular ligament, the MCL on sublime tubercle, as we have said before, and the brachialis spine. There is an important study about the coronoid process did by Giannicola and his group concerning the importance of the coronoid process in the stability of the elbow. They calculate an angle, a coverage angle of the greater sigmoid notch, and they have seen that if this angle is closer, the elbow will be much more stable than, like shown in the left picture, than in the open angle, in which the stability of the elbow could be lower. This is important even in the fracture, because when we have a fracture of the coronoid process, we can have a loosening of the stability of the elbow, and it really depends on the fracture size. So in this kind of fracture, we have a classification, the Regan-Murray, that specify that we have 3 kind of fracture depending on the size, and on the type 2 and the type 3, the surgery is needed because the elbow will be unstable without a fixation of the coronoid. The importance of the coronoid process and the stability of the elbow is more important in the varus angle than in the valgus. And this is demonstrated by this study in which we have less than 50% of coronoid gone with the radial head okay, and more or less the stability in the valgus of the elbow is the same of the situation in which we have the radial head okay and the coronoid fixed. If we go on the opposite, the varus angle will change if we have a loss of 50% or more of the coronoid. So if we look at the same condition, if we have radial head okay with 50% of coronoid gone, as shown on the circle, we will have a varus angle, a loss of the varus angle, so an instability in the varus of the elbow. So the bone defect of the coronoid affects much more heavily the stability and varus of the elbow. We have then the soft tissue stability. On the primary stabilizer, we talk about the lateral collateral complex ligament. It's formed by 4 bundles: the LUCL, lateral ulnar collateral ligament, the radial collateral ligament, then the annular ligament, and the accessory collateral ligament. The most important maybe is the lateral ulnar collateral ligament, the LUCL, but we have to talk about the chordae obliqua and the quadrate ligament because they have to be considered a part of the lateral complex of the ligament. About the LUCL, we have 3 kinds of morphologies. Type 1, in which we have a bilobe ligament that go to the supinator crest. Then we have the type 2, in which we have the same insertion of the LUCL together with the annular ligament, and then the most of type, we have the type 3, in which we have the coalitions with the annular ligament inserts at the broad base of the supinator. So the most of the time the LUCL is considered the most important ligament in the lateral side that prevents the posterolateral and rotatory instability of the elbow. But in this study the conclusion are that this is real, but it's real that we have to think to all the complex on the lateral side that is able to prevent the rotator and posterolateral instability of the elbow. We move to the medial ulnar collateral ligament complex. So we move to the medial side and we have 3 components: the anterior bundle, we have the posterior bundle, and then the transverse. The anterior bundle of the medial collateral ligament is an important constraint to valgus and rotational stresses, and mostly with the elbow flexed between 30 and 100%. And this is more important when we have some other comorbidities. So if we have a radial head fracture with MUCL lesion, we have a severe valgus instability, but the most of this is due to the AMCL lesion. And we can see in the left or in the right diagram, we see that more or less the stability in valgus of the elbow is more or less the same if we have radial head fracture or if we have an intact elbow, or if you have a radial head fracture with a posterior bundle of the medial collateral ligament broken. But if we have even the anterior bundle of the medial collateral ligament, look how increasing is the instability in valgus of the elbow. So it's really important that the anterior bundle has to be repaired in the case of a lesion. And as we can say, during the movement, the most of the tension is during the bend of the elbow between 30 and 100 degrees. The posterior bundle of the medial collateral ligament forms the base of the cubital tunnel and is a thickening of the joint capsule. So we have a loosen extension and it's tight and flexion. In this study is shown how the posterior bundle of the medial collateral ligament could lead to lower instability once broken of varus and intrarotational stability. Even for the transverse bundle of the medial collateral ligaments, we have to change some ideas because in these two studies have shown that this is not an accessory ligament but a connective part controlling the valgus stability of the elbow. Then we have the secondary stabilizer. We have the radial humeral articulation and in particular the radial head. It has two articular surfaces, the humeroradial joint and the proximal radioulnar joint, with two different morphologies. We have a fovea for the capitulum humeri and a smooth convex circumference for the surface. The radial head has two biomechanical roles. The first is transmitting forces across the radiocapitellar joint and the second adding tension on the lateral ulnar collateral ligament. It gives varus valgus laxity when it's broken and restored after radial head replacement. Humeral ligament stabilizes the radial head during full rotation. And we have always to avoid capitellectomy as first approach when we meet radial head fracture because we increase the risk of valgus and posterolateral instability that can hesitate in LUCM lesion or in ulnar neuropathy. And this is widely demonstrated in the literature that the radial head has contributed to the stability of the elbow, especially in the valgus stability. As we can see, less in the varus, but if you have a radial head fracture associated with a ligament lesion, the instability will increase absolutely. So every time you observe a non-isolated radial head fracture, the elbow instability increases significantly. We can find different morphology of the radial head. This is important to know because sometimes, especially when we have to fix radial head fracture, we have to plan the kind of morphology in order to have a better fixation. At the end, we talk about the dynamic stabilizer that are represented by the tendons. So we have the common flexor pronator tendon that originating from humeral shaft like the brachialis, the triceps and the biceps. Then we have the common extensor tendon that are originating from the forearm. The force that this stabilizer exerts and the recruitment pattern that is employed remain still an area of investigation, even because we start talking about the elbow like one of the most complex joints we have. So to conclude, we can affirm that injury mechanisms give us an indication of the possible associated lesions. Never forget to assess the integrity of the ligamentous complexes that are crucial for elbow stability and to repair them when necessary. When you observe a radial head fracture, you have to check always for posterolateral instability and assess coronoid process and LUCL. When you observe a coronoid fracture, you have to evaluate if it's interested the apex or the anterolateral facet to identify any possible radial head fracture or MUCL lesion. When observing an elbow fracture, never forget to check proximal and distal joints because the most of the time the trauma are indirect, so we can have lesion up to the wrist or to the shoulder. Thank you all for your attention.